All right, good morning, everyone, and welcome to the UCSF Center for Global Nursing's Global Nursing Impact Series for December. We are excited that you're here. This series, as you know, aims to provide a platform for our nurses, global partners, to share their remarkable work, offer valuable insights, and inspire our global community. Following the presentation, there will be a short question and answer, so feel free to write your questions throughout the presentation in the Q&A box. For those of you that don't know me, I'm Rebecca Silvers, Director of the Center for Global Nursing, and I'm honored to introduce this month's speaker, Daniel Maweu. Daniel is the co-director of UCSF's Global Action in Nursing Initiative and works as a Partners in Health maternal child workforce development specialist, supporting nurses and the midwifery workforce development efforts in Liberia, Sierra Leone, and Malawi. His passion lies in strengthening resilient maternal health systems, and he is a dedicated advocate for respectful, dignified maternity care for all women of reproductive age. He is a highly accomplished nurse leader with a Bachelor of Science from Kenyatta University. He also holds a Master's of Science in Nursing with a midwifery specialty, a Master's in Public Health, and is an advanced postgraduate diploma, has an advanced postgraduate diploma, in global maternal child health. Please join me in giving a warm welcome to Daniel Maweu.
Yeah, thank you so much, Rebecca, for the wonderful introduction, and welcome everyone for today's webinar. So basically today we will be talking about really and illustrating how to integrate targeted task sharing skills into nursing and midwifery curriculum. And this is to prepare nurses and midwives for primary health care and improve quality of care in order to really reduce preventable maternal and neonatal death during childbirth. And this will be in case study of Liberia. And you are welcome. I'll be glad to really us to have a wonderful discussion at the end of this presentation. And so basically we're going to look at the Global Action in Nursing project, in abbreviation that is GAIN project. We'll look a bit on the background of the work in Liberia. We'll have a look at the registered nurse midwife curriculum revision process. Then we'll together look forward and have an open discussion at the end of this presentation. So the Global Action in Nursing is an NGO which started in 2017, and this is basically meant to provide clinical and leadership training to nurses and midwives in high-risk communities with the goal of reducing preventable maternal and infant death during childbirth. And so since 2017 started in Malawi, which is in Africa, and by 2019, it expanded within Malawi. Initially, it was in Partners in Health, Malawi, then expanded to another NGO within Malawi called GAIA. Then in 2020, expanded to Liberia and Sierra Leone Partners in Health. And then in 2024, we expanding to Partners in Health, Lesotho. So basically, our model encompasses first a leadership and clinical training for nurses and midwives, which is usually a brief training, leadership training, and with targeted skills training on maternal and neonatal care. It is then followed by a year-long clinical mentorship at the primary health centers and district hospitals at the countries where we work in the 4 countries. And of course, we have also nurse education advisory boards, which really guide our work in terms of scholarships and education programs. We guided by 3 main objectives, and the first one being expanding the nursing workforce, the second one being establishing a pathway for nurses to upgrade their education, and the third being creating a cadre of expert providers skilled in patient care and leadership. And basically, this is through clinical mentorships, through short trainings and also through scholarships, and again, creating a pathway for the nurses who are training to be integrated in the practice through fellowships, and of course, also supporting the training of the nurses and midwives didactically at the classroom level. So just to highlight where Liberia is, it's in West Africa, bordering Sierra Leone, Guinea, Ivory Coast, and with a national population of around 5.19 million. I just want to take us through a bit of a situational analysis on maternal and neonatal profile. Currently, maternal deaths in Liberia, it's around 742 estimated per 100,000 live births. And some of the direct causes of this mortality include obstetric hemorrhage leading at 30%, with hypertensive disorders at 24.5%, sepsis, postpartum sepsis 20.4%, and safe abortions at 17%, and obstructed labor accounting for around 7.5% of the direct maternal deaths in the country. For the neonatal deaths, currently it's 37 neonatal deaths per 1,000 live births. And of these, some of the causes of this, we have birth asphyxia and prematurity, 28% each, sepsis accounting for 22%, congenital abnormalities accounting for 9%, and acute respiratory infections really accounting for 7% of the neonatal mortalities in the country. The currently midwifery workforce is the density is 7.9 midwives per 10,000 of population, against the global average of 37.7 per 10,000 of the population. And 29% of the facilities currently do not have a midwife. 80% of births do occur at a facility, and 84% of the births do take place with a skilled provider, either a physician or a midwife. But today, our target really is to look at the bigger a profession, which is again the nurse-midwife profession, which accounts for 72% of the birth providers in the country. Just a bit of more data. We have 31% of married women have unmet family planning needs. Cervical cancer is a big problem in the country, and with the cancer-related deaths, it leading the cancer-related deaths at 18.5%, and we do have very low access to obstetric ultrasound, just like other low middle income countries. It's as low as 6% of access. So basically, looking a bit on why do we have such high maternal and neonatal deaths in the country. One of the key contributors really is delays of the patients seeking healthcare. Sometimes it felt like we have an emergency at home, and then we get that there's a delay deciding to seek healthcare and probably decide to seek other alternative means of healthcare. Sometimes the delay could be due to challenges accessing the facility, maybe due to poor roads or lack of transport. And sometimes they have made it through to the facility, but then they don't really receive the adequate care which they need at the facility due to several factors which have been flagged in the maternal and neonatal reviews, like limited resources, again, skill gaps, where we get to find that the providers not identifying risk factors during antenatal clinics, poor management of obstetric and neonatal emergencies, poor management of labor, inadequate skills and knowledge in other key obstetric and neonatal skills, in effective communication within the team and also within to the patients and the community. Sometimes you find the patient being discharged too early from the facility, and they get complications due to that early discharge and missed diagnosis of medical conditions during antenatal clinics visit and also during labor. And of course, sometimes you may find, we found a few cases of transfusion reactions. Now, when you look at these contributing factors, one thing you'll notice that majority are preventable. And here we get to see again that quite a number of them again can be really prevented through capacity building and looking at the biggest workforce, that means the midwives. So that brings in the task sharing and task shifting approach really to try and see whether we can really reduce these maternal and neonatal mortalities and morbidity. Just a snapshot of really what does this mean for task shifting. This really rational redistribution of tasks amongst the health workforce teams, and basically in order to make more efficient use of the available human resources for health. And these are cases where you may find really that task is really originally done by a highly qualified health worker, but we have shortage of the same, and the skill can still be done by a healthcare worker who has shorter training with fewer qualifications. Whereas now, in today's webinar, we're focusing on the task sharing, and I know the two are used interchangeably, but here we're looking at building collaborating teams of experts, and again, less qualified cadres who are able to really share the clinical responsibilities and really communicate together, work together collaboratively to ensure that we achieve the high result. So we're looking at how can we ensure we promote task sharing through training. Now, our key target here is to ensure we get safe birth. And this is our main target when we were thinking about this curriculum, which we were revising. We wanted to ensure that Liberians do get safe births. And through the continuum of healthcare during pregnancy, and again, the interrelated factors like equipment, professional collaboration, community involvement, health system strengthening, accessibility of health facilities, and prioritization of, data-driven decision-making, we still find that with all these, we still need access to skilled birth providers or attendants who can really provide respectful maternity care. And this is where we really focused on how do we ensure that we produce nurse midwives who can really ensure that all the women in the country receive access to the best respectful maternity care. And this is through pre-service training, which is again where the basic training of the nurses, and through transition, creating a pathway for them to transition properly through fellowship, ensuring that we have well-trained staff in sufficient numbers, longitudinal clinical mentorship, and in-service training that makes them specialized. And so in our curriculum, really, it was targeting in-service training specialization for nurse midwives. This is in alignment with the Liberia Board of Nursing and Midwives, the GAIN and the PIH goals of establishing a pathway for the nurses to upgrade their education, and for us to transform the nursing and midwifery educational programs and align them to really the changing health landscape, ensuring that we really create a workforce which is ready for the primary health care and changing educational landscapes currently, which is really evidence-based driven, and also ensuring that we are able to produce competent midwives who will really positively influence that change to ensure we lower the maternal and neonatal mortality and ensure we get to improve the health indicators. So to achieve this, we used the backward design model as we were really working through revising this curriculum. Now, what we did was we first looked at identifying the desired result. What product are we looking at what competence of a student, what competence do we want the registered nurse midwives to have at the end of the training? That was really our primary goal. And to achieve this, really, we did a lot of situation analysis, looked at the data, looked at the also learning from other international practices, and also looked at the existing curriculum to take note of the gaps and compare them with the situational analysis findings. When we got to identify really the competencies we needed, then we looked at how will we ensure that the nurse midwife we are going to train achieved these desired competencies. And so we looked deeply, ensuring that we are able really to measure and evaluate ensure that we are able to evaluate the impact of the curriculum throughout, and of course ensuring that we are able to really get the required resources to ensure that the learning experience and instruction really achieved that desired results. Now, I will just extract the first step, which is identifying the desired results. And this is really what made us really come up with a vision for the curriculum. And in this, we looked at the enduring. One of the key things we really concentrated around was ensuring the midwife really, we are able to produce a midwife who has the key competencies. And we looked at what is that enduring understanding we need this nurse midwife to have by the end of this training. So we looked at the ICM competencies. That was really a must-have. We needed to have a midwife who is able to be a leader as well, respectful maternity care, and a critical thinker. And then we looked at the less important to know and do skills. We needed to have a midwife who is able to really practice evidence-based practice, an innovator, a researcher, educator, and quality improvement, and also looking at task sharing. And of course, other skills which really were worth being familiar with, but again, were not as priority as the enduring understanding. And here we looked at strategic planning, project management, and nursing informatics. And with this, we're really looking at training a highly skilled nurse midwife specialists for the country. So we basically were targeting to train a generic nurse who is at the basic level of entry to a specialist in registered nurse midwifery. These are the key competencies which we included in this curriculum. General competencies like research, critical thinking, evidence-based practice, core competencies, 3 of them through the journey of the pregnancy, from the pre-pregnancy to antenatal care, to the care during labor and birth, and also the ongoing care of the woman and their family. We started the project, the revision of the curriculum, January 2023, and we completed this in November 2023. And so basically, in a nutshell, we started with a baseline survey where we adopted some recommendations based on what we learned, the gaps were. Then we did a desk review for international best practices where we identified the essential competencies which we needed to adopt, and we adopted them. Then we looked at the curriculum redundancy, and we identified those gaps which were really needed to be addressed. And then we streamlined that. And then we involved stakeholders who reviewed this curriculum and ensured that the curriculum content is aligned to the national goals. Basically, some of the key things which through this journey were able to ensure we integrate this curriculum was in integrating respectful maternity care across all the courses. Initially, it was just in one course, but we integrated in all the courses within the program. Evidence-based midwifery practice, point of care ultrasound was also introduced to, again, ensure that the midwives are able to diagnose women early and refer or involve other healthcare workers to ensure the proper management during complications. Cervical cancer screening and treatment also was integrated, and nursing informatics, community midwifery, and mental health. So the implementation, we did validate the curriculum using national stakeholders to promote buy-in. Then we printed this curriculum and we disseminated the curriculum to the schools where the training was to be done. And we trained the faculty on the new curriculum and what it changed, and then proceeded with the implementation. So as part of the partnership between Partners in Health and Global Action in Nursing, then the first class will be receiving scholarships so that we can pilot this curriculum. Monitoring and evaluation will be continuous, and really continuous. The curriculum revision process and refinement will be a continuous improvement process. This is just a snapshot of how our curriculum looks like. It's a national competency-based post-basic registered nurse midwifery curriculum for Liberia. When midwives are educated to international standards and integrated into health systems, over 80% of maternal and neonatal deaths can be averted. This is really one of the key lessons we've learned, and we're trying really to ensure that we address that through targeted training of the registered nurse midwives. Looking forward really and see how task sharing plays a role in curriculums, and especially in service training or didactic training right from the school. We can really invest in quantity and the quality of providers, midwifery providers with the right skills and the correct skills to really be able to provide that universal healthcare, advancing the role of the midwives really they play using the midwifery-led care model right to the basic, to the grassroots, the hard to reach areas, and ensuring that every woman receives at least one obstetric scan during their pregnancy. And of course, ensuring that every mother, every baby counts, and that we are able to lead, midwives lead that the prevention and management of cervical cancer. And of course, we are able to prepare midwives for the future as change makers in the policy, on the policy making table. Here are some further recommended readings for you. And basically, you can learn more about our work. And as I invite Rebecca to take us through the next session, which is a question and answer session. Thank you so much.
Daniel, thank you so much for that amazing presentation and the work that you're doing with Partners in Health and Global Action in Nursing in Liberia. I know that you guys work in multiple countries. Sorry, I was going to start with my question. I don't see any yet in the chat, but I want to say to all the attendees, if you have any questions for Daniel, please put them there. But my first question is, since you guys work in Liberia, Sierra Leone, and Malawi, and this project was based in Liberia, is this a proof of concept project that you guys are going to then move forward, or do you have a vision for this for all the countries you work in, or is this just a specific project based on the needs in Liberia?
Yes. Thank you so much, Rebecca. And really, it's a good question. So we are in 4 countries. This particular one was based on the need with the stakeholders and also the specific country need in Liberia. And the gaps we really were identifying while we were doing the clinical mentorship, which we actively involved in at the far southeast of the country. However, again, lessons learned from this, again, being shared with the countries where we are. And again, our expertise really goes into advising the nursing and midwifery councils in these countries, and where really they need support, then we provide that, because again, we've learned a lot through the process in Liberia, and we can support them with the same in the other 3 countries. Thank you.
Thank you so much. There's a question in the Q&A. What are the job vacancies available for midwives for Liberia?
Yes, so the government there is quite committed in reducing the maternal and neonatal deaths. You'll notice that as I was presenting, that 29% of the facilities didn't have a nurse midwife or a midwife. And so basically what has been happening is as they train, they are absorbing all the nurses and midwives. Of course, budgetary challenges are there as just like other low and middle income countries. But again, they really ensuring that every other midwife currently who is graduating from the schools gets to be posted to the various facilities. And again, based on availability of budgets with partner support, then ensure that they're integrated in the workforce.
Thank you so much. I think it's so impressive to develop a curriculum at a national level because the later impacts on healthcare delivery are things that you guys are measuring and tracking. And so from the curriculum to the impact, how when you're measuring your impact of the specific curriculum, how will you know that this curriculum has kind of changed the outcomes for your patients? Or are you looking at nursing competencies, or are you looking at patient delivery? Another question.
That's a good question, Rebecca. So currently the curriculum is being piloted in one school in the country. And again, several other schools have shown interest of implementing the curriculum in their schools. Now, what we've done as part of the implementation is that we first understood that really curriculum is just as good as its implementation. And so as a program, as a partner, we provided the initial ultrasound machines and also the thermocoagulators for the cervical cancer treating and basic supplies and equipment for the same. So the reason we did this, it's because we really wanted the curriculum to be implemented as best as possible based on the way it's been designed, and for it to achieve the competencies, the midwives to achieve the competencies which are outlined in the curriculum. What we're looking at with providing these supplies and equipment and training the faculty is that the nurses and midwives will leave this first in 1.5 years. The nurses and midwives will be graduating, and we will at the time hopefully track and follow them up and see how the impact of this curriculum translates really to the patient at the bedside. And that is really part of the curriculum revision process because it's continuous. We have to really review it as it is being implemented at the classroom and follow up the products of the curriculum and see whether it's really achieving the competencies at the bedside.
Yeah, I think that's incredible. I think a lot of curriculums, you guys are really doing the work, and there's so many trainings that get implemented across the globe in different specialties, and there's not a lot of tracking of the impact. And I think tracking the impact is where there's so much opportunity to really see if all the efforts we're making really do change patient care, and if then they're applicable in other places. We have another question and comment in the chat. Thank you, Daniel, for sharing this great work. I would like for you to highlight the challenges that you experienced throughout the process, but also how supportive was the government in all this work in Liberia? Last question.
Yes, that's a very good question, Rebecca. So in the curriculum revision process, you'll notice that you mentioned stakeholders multiple times through the process of the curriculum revision. Amongst those stakeholders, largely were comprised of the government at the various ministries and departments. The reason is, again, getting that buy-in at that curriculum development stage is important and ensures really that you get the curriculum implemented and really accepted by the government especially. So we involved the Ministry of Health at the various levels, Maternal Health Division, all the way up to the Minister of Health. This curriculum was actually validated by a session where the Minister of Health really attended to validate the curriculum. So we involved the government at the development of the curriculum and also involved them at the dissemination of the curriculum, and they will be also involved in the dissemination, in the implementation of the curriculum. The main goal is that this will also move further to inform the revision of scopes of practice, schemes of work of these nurse midwives in future, that they graduate as specialists and recognized as specialists at the Ministry of Health level, and also for them to also receive that specialty treatment by the government. So yes, we've included the government throughout the process, and they were really involved. Thank you so much, Rebecca.
Yes, these have been amazing questions in the chat. Thank you, everyone. And mostly, thank you to Daniel for this wonderful presentation. I know we could talk for hours, but we just have our 30 minutes together. We are so grateful for your presentation, your leadership in nursing, and the work that you're doing to support midwifery development and make midwifery care accessible to all. So thank you, everyone, for joining us today. Daniel, the presentation will be on our YouTube channel. Definitely check out GAIN, Partners in Health, and all the amazing work that they're doing. Everyone, thank you for joining and have a most wonderful day. And we'll see you in the new year.
Thank you, everyone.